Able to hear, no, sir?
Yeah.
Yeah. Very good morning to all the doctors who had on the webinar. This is very interesting. This is the presidential action plan, which was made on clinical genetics. Month by month, we planned around 12 months. And there is a beautiful, good response where we got in the first webinar, second webinar, third webinar, and moreover, they are seeing on the recording platform, also YouTube platform. And this fourth webinar of clinical genetics, basically based on the dysmorphic child, approach to a dysmorphic child, how the genetics involved. So this is the today's discussion, and I request our president Sunkoj Bhaskar sir, president, to say a few words before starting, sir.
Yeah. Thank you, Dr. Sridhar, and good morning, all, and happy Sri Ramanavami. Greetings to you all. Very auspicious day. Thanks to our guest speaker, Dr. Madhulika Kabra Madam, for accepting our, particularly Dr. Prajna Ranganath's invitation to be here as a speaker. And again, our another guest, Dr. Srinivas Mukhi. Am I audible?
Yes, sir. Yes.
Yeah. Our another guest, Dr. Srinivas Murki, will be making a few opening remarks. Here I should mention one thing about Srinivas. During during pandemic, he was the person behind me who started this online webinar series. He guided me, and he started this kind of webinar presentations. That too started with the genetics only. If Dr. Srinivas remembers, started with the genetics from Fernandez. And it is still being continued and is being appreciated by everybody, because I proudly say IAP Twin Cities branch was the pioneer of webinar series across the India. So credit goes to Dr. Srinivas. Thanks, Srinivas, for being with us. And as you all know, last topic was about Mendel and beyond decoding patterns of inheritance in clinical practice by Dr. Priya Ranganath. Then after that, a case-based discussion about the genetic counseling based on inheritance by none other than Dr. Prajna Ranganath. Dr. Prajna Ranganath is the backbone of this entire 12 webinar series. She's working hard despite being a festival, an important day for her. She's with us with enthusiasm and interest. It shows her zeal to spread genetics among all the healthcare professionals. And today's topic is really very interesting, particularly people like me, clinicians, wherein day in, day out, we see syndromic or abnormal phases, and many a times we don't arrive to the diagnosis. We get confused. Then we try to understand. Sometimes we are successful. Sometimes we miss the diagnosis. So for this, we have a senior personality who is none other than Dr. Madhulika Kabra Madam, with vast experience being the former HOD of pediatrics and as well HOD of the Department of Genetics of prestigious Institute AIMS, New Delhi. So with these few words, once again, I sincerely thank you all for attending. I request you all to participate in big number and make benefit of this. And with the knowledge which we gain today, we may be able to pick up all the syndromes, if not most of the syndromes and dysmorphic phases. So thank you one and all. And once again, I thank our guest speaker, Dr. Madhulika and Dr. Srinivas Murki. And I thank my body, particularly Dr. N. L. Sridhar, Dr. RSV, Mr. Satish, who are all with us to do this program. Thank you once again. Over to Dr. Sridhar.
Yeah. Before starting the program, I request Srinivas Murki sir, our today's guest, to say a few words so that we can start the program, sir.
Thank you, Sridhar, and thank you, Dr. Bhaskar, sir. I think happy Sri Ramanavami to all of you and to us. And what a great day to start the day with clinical genetics. Yeah, I think we have evolved a lot in genetics, and the key role has been played by many geneticists who are coming up and adding to the field of clinicians. So we're getting more genetics adding to our health. for pediatricians, for neonatologists. And we have moved from making simple diagnosis like Down syndromes or Pataus or trisomy. We have moved from that to making complex diagnosis and also in prevention of many of the lethal chromosomal abnormalities. So we all started our MBBS days when we had only few diagnostic things to evaluate, and then we moved from there to complex disease and complex patterns. How we are making clinical diagnosis and then being supported by genetics. So future is going to be also in therapeutic genetics, and I'm sure Pragna and the group working a lot on how do we help in improving the lives of people who are affected with genetic aberrations. So I hope this series of lectures is going to guide us in evolving ourselves into good clinicians, in making correct diagnosis, in counseling the patients rightly, and in probably in helping us to understand how future is going to evolve for genetics for all our patients. And for today's talk, we are privileged to have Dr. Madhulika Kabra. She is one of the giants in the field of genetics. It's really a pleasure to hear to her. And thank you, Pragna, for bringing Madam to this forum. And thank you, Pats, for involving me.
Thank you, sir. So nice of your words, sir. And now I request RSV Sri Krishna, our treasurer and coordinator for this program, to start the things. RSV Sri Krishna.
Satish is there.
Yeah, I think we can start, ma'am. Dr. Prajna Raghunath, madam, Dr. Garu, please start the program, and you can introduce Madhulika Kabra, madam, and you can start, please.
Thank you, sir. So, at the outset, a very good morning to all of you and happy Ramanavami to everyone. Thank you, Bhaskar, sir, once again for this opportunity. And it's definitely the need of the hour because we know that all pediatricians come across cases which have a genetic basis. So, it's very important to understand the concepts of clinical genetics in order to be able to diagnose and manage these patients properly and also counsel the families accordingly. Before we move on to Professor Madhulika Madam's talk, as per our usual pattern, I'll do a brief recap of what we covered in the previous talk. So, the previous webinar session that we had in March, we had discussed about patterns of inheritance and primarily about Mendelian and non-Mendelian patterns of inheritance. So basically, again, coming back to this particular figure that we have been projecting in the past sessions also, just to remind everyone that genetic disorders are of several types. And simplistically, if we have to categorize them, broadly, we can categorize them as gross chromosomal anomalies, the chromosomal microdeletions and microduplications, and the single gene disorders. So, this was what we discussed in the previous session. Patterns of inheritance we can broadly classify as Mendelian inheritance patterns and non Mendelian mechanisms. The Mendelian inheritance patterns are further classified as autosomal dominant, autosomal recessive, X linked, and Y linked. And the non Mendelian mechanisms of inheritance include trinucleotide repeat expansion, mitochondrial inheritance, imprinting related disorders, uniparental disomy, mosaicism, oligogenic inheritance, multifactorial inheritance, and epigenetic inheritance. Because this is just a recap, I'll not be going into the details. I'll just be briefly highlighting the very important points here. So, autosomal dominant inheritance is caused by a single heterozygous mutation and it is passed on from one generation to the next, which is why we also say that it has a vertical transmission and it may be transmitted to offspring of either sex. And there is an equal chance for males and females to be affected. And generally, one parent is affected, there is a 50% chance of each offspring being affected. Of course, many of these autosomal dominant disorders, common examples being neurofibromatosis type 1, tuberous sclerosis, Marfan syndrome, etc., have variable expressivity, which means that there can be significant variations in the phenotype of the same disease from one affected individual to another, and sometimes not only interfamilial but even intrafamilial variability is very well known for autosomal dominant disorders. So this is a typical example of an autosomal dominant disorder with variable expressivity, tuberous sclerosis, where some individuals may have predominantly the cutaneous manifestations, some will have the intracranial manifestations as well. In addition, some may have the cardiac rhabdomyomas, the renal angiomyolipomas, and so on. And then there's this other concept of reduced or incomplete penetrance or skipping of generations with autosomal dominant disorders, where some individuals may have the mutation but may not have any phenotypic expression at all. So individuals who have the mutation but who do not have any phenotype related to that disorder are said to be non-penetrant, and the disorder is said to have incomplete penetrance. And all autosomal dominant disorders need not be inherited. Likewise, for many X-linked disorders also, and also for a majority of the chromosomal abnormalities, the mutations or the abnormalities can arise de novo also during gametogenesis or embryogenesis. And in this case, of course, the parent would not be affected, but if the individual has a de novo mutation, he or she will manifest the disease and then pass it on to the next generation also. Autosomal recessive disorders, on the other hand, are caused by biallelic variants, where both copies of the gene have to be mutated to produce the disease phenotype. So here, when the same mutation is present on both copies or both alleles, the individuals are said to be homozygous for the mutation. When two different mutations are present on two copies of the same gene, the individual is said to be compound heterozygous for the mutations. And in almost all of them, the parents will be carriers, but usually will be unaffected. And when both partners are carriers, there is a 25% chance of each offspring being affected. So many common disorders that we see have an autosomal recessive pattern of inheritance, including beta thalassemia, sickle cell disease, many of the inborn errors of metabolism, many of the skeletal dysplasias, spinal muscular atrophy, and so on. And then X-linked inheritance actually refers to the inheritance of disorders which are caused by mutations in genes present on the X chromosome. So because males have only one copy of this, generally males who have the mutation tend to be affected. And typically in the X-linked recessive disorders, classically we are taught that females are not affected, only males are affected. This may not always be the case. We can have mild manifestations in female carriers also. But for the X-linked dominant disorders, even the heterozygous females are expected to be affected. So X-linked recessive inheritance, if the mother is a carrier, there is a 50% chance of each male offspring being affected and a 50% chance of each female offspring being a carrier. But again, like I mentioned for autosomal dominant disorders, sometimes the mutations may arise de novo. Sometimes there could be something called gonadal mosaicism, where the mother's blood DNA may be showing a carrier negative status, but the mutation may be present in a proportion of the gonadal cells. And because of that, there could be a recurrence in the next male offspring as well. So common examples of X-linked recessive disorders include Duchenne muscular dystrophy, hemophilia A, and hemophilia B. X-linked dominant inheritance, here the heterozygous females are also affected and hemizygous males are also affected. In some X-linked dominant disorders, the phenotype is very severe in the hemizygous affected male individual, and that can result in perinatal mortality, a classic example being Rett syndrome. Sometimes the affected male individuals will survive and they will have manifestations which could be more severe than in the affected female individual. A classic example for that being X-linked hypophosphatemic rickets. And then broadly, the non-Mendelian mechanisms we already listed in the first slide. Amongst them, the relatively common ones are the triplet repeat expansion disorders. So trinucleotide repeats are stretches of repeats of three nucleotides in some regions of the genome. Normally also these repeats will be present in these regions, but when there is an expansion or increase in the number of repeats beyond a certain normal stable level, which is called the threshold, the disease occurs. So common examples of trinucleotide repeat expansion disorders are Fragile X mental retardation syndrome, myotonic dystrophy, type 1, Huntington disease. some of the spinocerebellar ataxias, the SCAs type 1, type 2, type 3, type 6, and type 7, and so on, Friedreich's ataxia, and spinobulbar muscular atrophy. Mitochondrial inheritance is related to mutations in the mitochondrial genome. So because the mitochondrial genome comes to the offspring only from the mother, therefore, it is only the mother who transmits a mitochondrial mutation to all her offspring. It is not maternally derived. So you would get a typical matrilineal inheritance for mitochondrial genome associated mutations. And the common examples of mitochondrial disorders. So we need to remember that many of the mitochondrial respiratory chain disorders caused by mutations in the nuclear genome also. But the ones which are caused by mutations in the mitochondrial genome only follow this matrilineal inheritance. So here common examples include MELAS, MERF, Leber hereditary optic neuropathy, some of the forms of Leigh disease. Some forms of Leigh disease are caused by nuclear genome mutations as well, Kearns-Sayre syndrome, and some forms of deafness. Then the genomic imprinting related disorders, where normally for some genes, only one copy is active and the other is inactive or imprinted. That is a normal phenomenon, and that depends upon the parental origin. So in some regions, the paternally derived copy will be silenced. In some regions, the maternally derived copy will be normally silenced. So when the copy which is supposed to be active gets a mutation, that's when the disease happens. So a common example is Prader-Willi syndrome. And of course, you have other disorders, including Angelman syndrome, Beckwith-Wiedemann syndrome, Russell-Silver syndrome, transient neonatal diabetes, and pseudo-hypoparathyroidism type 1. As you can see, several mechanisms lead to these alterations of imprinting, including deletions, uniparental disomy, imprinting center mutations, and others. So I'll stop with the recap there. And now we'll move on to today's session. And we are extremely privileged to have Dr. Madhulika Madam as a guest speaker today. I would like to thank Madam from the bottom of my heart for accepting our invitation readily and agreeing to share her experience and expertise with us. I'm sure Madam doesn't need any introduction to the pediatricians across the country. Madam just superannuated in January this year. So she was the professor and head of the Department of Pediatrics at the All India Institute of Medical Sciences, New Delhi. And she was also in charge of the Division of Genetics for several years. And Madam has numerous awards and honors to her credit. And Madam has about 450 publications to her credit, something that most of us can only dream about. She's been working in the specialty of medical genetics for the last 30 years. So she's definitely one of the pioneers and the doyens in the field, as Bhaskar sir had pointed out. And Madam's areas of interest include rare diseases, intellectual disability, dysmorphology, storage disorders, and newborn screening. She has, she's one of the leaders in this field, as you can see from all the achievements that Madam has to her credit. She has been the recipient of Dr. I.C. Verma Lifetime Achievement Award of the Indian Society of Human Genetics in 2016. Also, the Dr. I.C. Verma SIMG Outstanding Scientist Award in 2017. She's been past president of the Society for Indian Academy of Medical Genetics. She's a member of the National Committee for Rare Diseases, member of the Central Technical Committee for Rare Diseases of the Government of India, a member of the National Apex Committee of the Ministry of Health and Family Welfare for planning the route map and monitoring of activities of the National Consortium for Research and Development on Therapeutics for Rare Diseases. She's also a member of the International Pediatric Association's Program Area Working Group on Rare Diseases. Of course, these are just a few of Madam's numerous achievements. There are many more. And once again, Madam, we would like to thank you for accepting our invitation and graciously agreeing to give this talk today. Thank you so much, ma'am. Over to you, ma'am.
Thank you, Prajna, for a very kind introduction. Greetings for Ram Navami to everyone. Thank you very much, the IAP team, for inviting me for this lecture. I'm really sorry, there's some problem with my video, which is coming at 90 degree, and I'm not able to amend it. So maybe I'll switch it off and I'll share my presentation. Will that be okay, Prajna? I'll switch off the video then, or let it be.
Ma'am, it's okay, I think, ma'am. Doesn't
Okay,
matter.
fine. So let me just share my screen.
Yes, ma'am.
So is this visible now?
Yes, ma'am.
Okay. So good morning, everyone. Um, I will be talking about approach to a dysmorphic child, a topic which is very dear to most of the clinical geneticists who started their journey in clinical genetics, say around 30 years back. So, interesting topic. And I would try to make it interesting for all of you as well. So, the outline for my presentation is going to be I'll be defining what is dysmorphology. We will also be discussing about definition of some important terms. Then we will, in the approach, we will discuss how do we approach a dysmorphic individual. So when do you suspect that the individual is dysmorphic? How do you do a systemic physical examination and get good clues for making a diagnosis? And in the present era, use of databases, I'll also touch upon. And I'll also discuss about the confirmation of diagnosis and the use of NGS-based testing in the present era. And in between, we will be having case examples. So I am from the era of I, as far as dysmorphology is concerned. And you all know that AI is coming up. But I think AI alone cannot solve the puzzle of a dysmorphic individual. So your eyes come first. So most of my presentation will be focusing on the traditional approach to a dysmorphic child. And definitely we will be touching upon how AI has helped in the area of dysmorphology. So defining dysmorphology is abnormalities of body structure that originate before birth. Many of you will be familiar with Dr. David W. Smith, whose book is like a Bible for us for dysmorphology diagnosis, and he had coined this term long back. Another important thing which I would like to mention in the beginning itself is that many times we see terms like funny looking kid or multiple congenital anomalies mentioned on the patient records. So funny looking kid obviously should never be mentioned, and I've seen this being mentioned on the cards. And also multiple congenital anomalies without a description also do not help us. So if we are writing congenital anomalies, it is always good to describe the abnormalities. And I think as a clinician, we need to make a habit to take pictures, obviously after taking an informed consent from the family. Then also in dysmorphology, we need to understand that specific features are important, right? So you need to pick up dysmorphic features which may help you taking towards the diagnosis. So some specific dysmorphic features for particular syndromes, actually even one feature at times can lead to the diagnosis. So, as a pediatrician, when I was also doing my MD, and now the exposure is quite a lot, but then earlier the exposure was limited, and there were few familiar phenotypes, as was being just said by the president, that there were few familiar identifiable phenotypes, and the pediatricians were happy diagnosing them. And most of the time, we would say that actually not really my domain. And even if you make a diagnosis, what can we do about this particular case? So as we go along, you will learn that I think it is very important to make a diagnosis, because it's not only treatment, but it is counseling and prenatal testing and many more things. So let us discuss some of the specific terms. As I said, these abnormalities originate before birth. So abnormal morphogenesis has these, there are many components of and types of abnormal morphogenesis. So the first one here, what I'm showing you is the poor formation of tissue, which is malformation or malformation sequence. Sequence means that because of one initial abnormality, there's a sequence of events which leads to a malformation sequence. The second could be unusual forces on a normal tissue. So this is called deformation, or again a deformation sequence. The third could be breakdown of a normal tissue, which could be disruption or a disruption sequence. And then there could be abnormal organization of cells, which is called dysplasia or dysplasia sequence. So these are four major types, and we use these terms many times. So we need to understand what do we mean about these terms. Then there are more, and we also know associations. So a group of anomalies that occurs more frequently than would be expected by chance, but they may not have a predictable pattern, and most of the time the etiology is unidentified. But we must know that all the anomalies may not be found in an association. Similarly, you have, as I said, pattern of multiple defects resulting from a single primary malformation is a sequence. Then you can have a complex, which anomalies of several different structures which lie in the same local body region during the embryonic development. I think this is important to remember when we are talking about complexes. And then the syndromes, which actually means running together. So a pattern of features which might lead to diagnosis of a particular syndrome. And here again, the etiologies of many of these is still unknown, but in the present era, we are sort of navigating and getting many answers in this particular area. Now, the major abnormalities which we can easily pick up and see and find that these are abnormal, there is importance of minor abnormalities also. So we need to remember that if there is one single minor abnormality, there can be 3% of the newborns can have associated major abnormality. If there are two, this increases further to about 10 to 11%. If there are three, then it increases significantly. And external minor abnormalities in the head and neck region and hand constitute 71% of the minor abnormalities. So minor abnormalities are usually seen in these regions, and single minor abnormality, or at times even two minor abnormalities, we might not need to explore and investigate, because most of the time we would not find an abnormality in the investigations. Now I'll give you this particular example because it is so important that we take a proper history in case of dysmorphology as in any other situation. Is this particular child and the mother who was pregnant was referred to us during her, you can see, during her 5th pregnancy, and she had multiple affected children. One first child died of cleft palate, and we did not have any details about this particular child. And she had multiple children, both boys and girls, and all had variable phenotype. All had some kind of facial dysmorphism. Some had cleft, some had eye abnormalities, and also had hearing problems. And this particular pregnancy, when she came to us, she was, I think, already about 26 weeks pregnancy. And the family was referred to us with a possibility of either a chromosomal cause, where it is maybe a normal chromosome, balanced chromosomal abnormality in the parents, either of the parents, and that's why multiple children affected, or a monogenic disorder. But when we saw this particular child and took the history of the mother, we came to know that the mother was taking valproic acid throughout all her pregnancies. Though on a lower dose now, but she was taking in all through pregnancies. And this is a very typical phenotype of fetal valproate syndrome. So you see this broad nose, a smooth long philtrum, and this thin upper lip. And this child also had the iris coloboma and a CHD as well, along with the developmental delay. Now, this mother had, the seizures were controlled for a very, very long time, and she could have taken of the anticonvulsant very long back. And unfortunately, even in the last pregnancy, we couldn't do anything, and the baby was born with a cleft palate. So this was actually fetal valproate syndrome. So even if you have multiple affected individuals in a family, it is very important to take a good history and find out if there is a teratogen exposure, even in a case of dysmorphism and developmental delay. This is another example of a dysmorphic syndrome, which is again because of a teratogen. I think all of you are aware. This is fetal warfarin syndrome, and this is a typical phenotype with these notched moon-like nostrils, and they have flat facial profile, and they have this abnormal stippling on the skeletal survey. So other important clues which you get from external examination, and these are the common malformations. You have neural tube defect, you have cleft lip and palate, and you should also look for if there is a central cleft lip and palate, and this kind of a profile, there can be brain abnormalities associated, particularly holoprosencephaly, and this could be chromosomal or even monogenic. And similarly, many other examples which I have told you, this is ectrodactyly, this is limb reduction defects, and so on and so forth. So these are the various type of defects which we come across whenever we are evaluating a dysmorphic child. And this is an example of a sequence which most of the time has mild manifestations, but it can be as severe as this. And you can see this is an example of disruption. You can see here, and these are the bands, and this is actually early amnion rupture sequence. In some of the very severe cases, because of these amniotic bands, the child can get all these abnormalities like eyelid coloboma and even clefts. So this does not have a genetic basis. It has not been identified till now, but it's a clinical diagnosis only. And then these are the examples of complexes, which is the slim body wall complex. And this is omphalocele, exostrophy, imperforatenous, and spinal defect complex, OEIS. So all these are kind of spot diagnosis if you have a very typical phenotype. And most of the times in these scenarios, you need not investigate the child extensively to reach to the etiology, because we know that for these, as of now, the causal genes or the chromosomal abnormalities have not been identified. And then the associations we are familiar with, there are multiple associations like vectoral association. And as I told you, here again, you may not be able to find all. But interestingly, another association which was thought to be an association, which is charge association, we know that now it is a monogenic disorder and the gene has been identified, and it's a autosomal dominant disorder. So what I mean to say is that even for the disorders, and even for the limb malformations and many other defects, the genes are being identified, and based on what case we have, we explore and decide further whether we need to do more investigations or no. Now, these are the examples of dysplasia, and you can all identify that this is a case of thanatophoric dysplasia. This is achondroplasia, and you can see the typical findings on the X-ray. And this is ectodermal dysplasia. This is X-linked ectodermal dysplasia. You can see the mother also affected. So Prajna, in the recap, told you about the broad categories of genetic disorders, and this will help me in taking you through when I'm talking about the inheritance patterns and other types of etiologies which cause dysmorphism. So you can see that the mother also has got sparse hair and eyebrows, and she had teeth abnormality, and the child has significant abnormalities in the hair. And what we find, it may not be very clearly seen here, that these children have full lips and they have a perioral pigmentation also. So this phenotype, if typical, is quite suggestive, and it can be picked up on clinical examination as well. And then you proceed with targeted testing like you can do in achondroplasia and ectodermal dysplasia. Also, you can do gene-based testing or even do exome. So with this background about the definitions and the common types of dysmorphic features, these are the common disorders which we are familiar with: Downs, Turner, Fragile X, mucopolysaccharidosis, some skeletal dysplasias, Noonan, some of the microdeletion syndromes, and so on and so forth. And some of them have got a very typical phenotype and can be diagnosed clinically. So we can all diagnose Down syndrome. At times it is difficult at a very young age, particularly in the newborn period. But then most of the time, with experienced eyes, you can pick up Down syndrome. And then you have, you know that you have trisomy 13, you have trisomy 18, and this is a typical phenotype of Turner syndrome. So we can all understand that in these scenarios, the first investigation is going to be karyotype testing. And with this, we will be able to make a diagnosis. Obviously, we'll be able to make a diagnosis with the advanced techniques also, like chromosomal microarray, but it is not recommended that if you have a typical phenotype of common chromosomal disorders, then you do CMA, you first do a karyotype, and then only we can decide. If we do not get an answer, then we can decide for further investigations. So, what is the aim of genetic evaluation? Whenever we are approaching a child, we need to know and provide useful clinical information to the family. So, what is the natural history? What is the prognosis? If there is any treatment available, and treatment of comorbidities, and very importantly, in most situations, counseling and prevention. So correct diagnosis is the key. And as Prajna must have taught you in the first session, that detailed history, family history is extremely important in any genetic case. And you have to take at least a 3-generation pedigree. Consanguinity is very important, which is very common in some of the areas in our country, particularly down south and some other areas. So this might give you clues towards the inheritance. And evaluation of clinical photograph, foot and old records. I think many times the old record and some of the doctors have put out some beautifully put notes actually lead towards the diagnosis and actually help you with the diagnosis. And old photographs with the parents have kept also help you. You investigate based on what is your suspicion. We will discuss this in detail later. You may or may not get a specific diagnosis. So I think we should remember that even in this era, in about 30% of cases, we may not be able to reach to a diagnosis, and that gives us the opportunity to investigate further, do some research, and try to identify the cause. So family history, importantly, birth defects are the genetic defects, abortions, stillbirths, and the parental age, particularly for mothers for Down syndrome. And it has been said that for autosomal dominant disorder, father's age is important. Antenatal, perinatal history, teratogens, I have given you examples. Physical growth and development. I think this is something very important, that majority of the dysmorphic syndromes are associated with developmental problems and growth problems. Family pedigree, consanguinity, as I have already told you. And as I said, dysmorphology requires an eye to pick up abnormalities. And now you have AI also to help you. So a good head to toe examination, good handles. So if we use handles like low set ears, depressed nasal bridge, even simian crease, this doesn't really help you in making a diagnosis, because these are common findings which might not give you clues for a specific diagnosis. So you have to have very objective dysmorphic criteria, a very good neurological examination, because some of the behavioral phenotypes can give you clues. And that's why whenever you are doing a search, you need to search with pearls of dysmorphology. So very specific dysmorphic features which will help you in making a diagnosis. So this is old teaching, but I really love this because this actually holds true as we progress in our journey in the area of medical genetics and particularly dysmorphology. So there are 3 models of dysmorphic diagnosis: the Scotland Yard model, the Dr. Watson's model, and the Sherlock Holmes model. So the Scotland Yard model is the typical model which we follow when we begin our journey. So you start, take medical history, perform medical examination, construct differential diagnosis list, formulate hypothesis, create a plan, and then reach to a diagnosis. Then you have that Sherlock Holmes model. You sort of sort of try to find out clues to make a diagnosis, and then pick up good clues, as I'm telling you, that pivotal pearls of dysmorphology, and then put them together, shortlist them, and then reach to a diagnosis. And then finally, the Dr. Watson model, which is As soon as the patient enters your clinic, actually made a diagnosis. So you will say, this is Dr. Watson's model, that, aha, I have a diagnosis. And after that, you start looking for the features which might sort of support your diagnosis. So here the examples are that you have this particular child with developmental delay and short stature. And here the clue lies in the eyes. So you see here that there's a disruption of the eyebrows here, which are actually faint, and this lateral eversion of the eyebrows, like our Bharatnatyam dancers, and this is Kabuki syndrome. So if you have this typical phenotype, the diagnosis is Kabuki syndrome. This, I think many of you will identify, this is Cornelia de Lange, short stature, hirsutism, synuphris, this upturned nose, and smooth philtrum, and then the diagnosis is Cornelia de Lange. But remember, for Cornelia de Lange, the phenotypes can be highly variable, and you can have a very mild phenotype, difficult to pick up clinically. And this is a typical phenotype of Rubinstein-Thiaby syndrome, this overhanging nasal bridge and smooth philtrum, and the typical broad thumbs and toes. And this is a phenotype which is Tricher-Collins syndrome, and again, it can be a clinical diagnosis very easily. So I was talking about dysmorphology databases. Earlier, we had access to which were paid databases like London Dysmorphology Database, London Neurogenetics Database, Syndroc, POSSUM, and so on and so forth. But now there are free databases, Face2Gene, which you can download on your phone or your computer. OMIM is freely available. And there's a very, very important there's a very, very important website which gives you elements of morphology, which helps you in defining the dysmorphic features. And it is extremely important because this is used world over. So if you use these terms when you are defining dysmorphology, anybody can interpret and help you out. So as I said again, use good handles, search literature, and use pearls of dysmorphology. So this is what I was telling you about. This is freely available, elements of morphology, human malformation, terminologies. So various dysmorphic features which you see, there are exact terminologies which are to be used when you are describing the phenotype. And this is very important. Even when you are sending a test for a CMA or NGS, if you describe in the terms which have been given here, then it will be very easy to even correlate the phenotype with the genetic diagnosis. So this is a standard nosology of clinical dysmorphology, and these terms which are called the human phenotype ontology definitions, which helps in searching and also making a diagnosis in the child, in an individual with dysmorphic features. This is Face2Gene. And this is a good program which can help you in making a diagnosis. But we need to remember, and there are new ones coming up now, the Gene Matcher and so on, many more. So it is very important that the program can only tell you, this is AI based, which the program has learned. So the program has to get familiar with a dysmorphic phenotype to identify it once you put in the picture. So as many pictures are put in the program and the computer learns that particular dysmorphology, it would be able to provide you with the diagnosis. So this is good one. We use it in the OPD for moving towards the diagnosis. And OMIM, is available for everybody, online Mendelian inheritance of man. And here you can again put in your phenotype and you can get in the answers. So these are simple ones which you can, if you have a case and you are interested in navigating further, then these can be definitely used. So I'll just give you an example of a child which we saw some time back. This was a 13-month-old girl with global developmental delay, primarily motor, with some dysmorphism, but we were not able to make a diagnosis with a no family history. With this dysmorphism, what we noticed was that the child had got a very large anterior fontanelle and she had a hoarse voice. And because of this and developmental delay, we were, after evaluating the hypothyroidism, which is extremely important in any child who has developmental delay and have some clues hypothyroidism, but that was all normal. And then we thought we will analyze the child by Face2Gene. And when we analyze the child by phase 2 gene, the first was Down syndrome, which obviously the child was not. And basically, the scatter graph gives you the idea that which are the different syndromes in sequence which can be thought of. And this was KBG syndrome. And when we went back and checked the features which can be present in early infancy, the child was sort of matching. And on doing whole exome sequencing, we could identify a variant in the gene causing KBG syndrome, autosomal dominant. It was pathogenic. It was good for the parents to know that it is a de novo, though the parents were so insistent that they got themselves tested also. But then this was a de novo variant and the risk of recurrence is low. We also need to remember whenever you are seeing a phenotype, the phenotype evolves with age. And at times it is very difficult to make a diagnosis in the later age group, in the adulthood. And that's why we need to go back to the literature to see that what is the phenotype in infancy, what is the phenotype in childhood, and what is the phenotype in adulthood. And now, as you know, we are even moving towards the fetal phenotypes. So this is a continuum, and we really need to, before making a diagnosis, we really need to go to literature and match pictures with the available literature. And you can see that our child's face matches with the phenotype of her age group. So later on, when we sort of went back to the literature, we were happy to know that wide anterior fontanelle and hoarse voice are in fact two features which have been documented in KBG syndrome. So though those are not very sort of, with this only we will not make a diagnosis of KBG syndrome, but if there are other features, I think these are some good clues for making a diagnosis. Okay, so we have talked about how to approach clinically history and the physical examination, and then we will go on to the investigations. So the specific investigations are chromosomal analysis, targeted gene testing, FISH, MLPA, chromosomal microarray, and exome sequencing, and as the case may be, do skeletal survey, neuroimaging, echo, and a metabolic workup also. Some of the metabolic disorders, as say like Zellweger syndrome, and I'll give you another example, can have dysmorphic features as well. So there's a changing trend of investigating a child with dysmorphism. Earlier, we only had karyotype and some specific diagnosis for single gene disorder, but we have now evolved over years and have many more modalities for investigations. And this, we are in the era of molecular dysmorphology. So I will just quickly go through this. Chromosomal abnormalities I have already talked about. Dysmorphism, developmental delay, multiple abnormalities are all the indications for doing a chromosomal abnormality. And as I said, if there is a specific phenotype, you will have to do a blood chromosome, and we would not jump onto other investigations like chromosomal microarray. And at times when there is, you are suspecting a chromosomal disorder and there are skin abnormalities like asymmetry and pigmentary abnormalities, you will not find abnormalities in the blood karyotype, but you will find abnormalities in the skin karyotype. This is an example of another syndrome which can be identified clinically, and this is actually 4p deletion syndrome. And the phenotype with this frontal bossing and the kind of face and with a very short philtrum, this has been equated to the Greek helmet phenotype. And this diagnosis, if you see many cases, it is easy, but at times it may be missed. And this is the example of a case where the blood karyotype will not help. And I hope you can see the pigmentary abnormalities here. This child had developmental delay, dysmorphism, spasticity, and the blood karyotype was normal. And it was actually Pallister-Killian syndrome, which is tetrasomy 12p. And there is mosaicism, and you have to take skin from the normal and the abnormal site and then do the chromosomes. And you can see the abnormality here that there's a tetrasomy of chromosome 12 in this particular case. So after the karyotype, the another test which you all know is FISH, and FISH is targeted, right? So FISH will only pick up the chromosome for which you are using the probe. So I think it is extremely important to remember that. And you can use it. You can use an interface FISH like targeting to chromosome 21 or 18 or 13 or sex chromosomes or any other chromosome. And it is still important for balanced structural chromosomal abnormalities when you can use metaphased fish for detecting the balanced chromosomal abnormalities. So no test becomes obsolete. Even for the chromosomes, for balanced chromosomal abnormalities, we need to do karyotype, even if you are jumping towards doing a chromosomal microarray in situations of chromosomal abnormalities when you are having dysmorphism, developmental delay, which is not pointing towards a chromosomal abnormality, specific chromosomal abnormality. Then you also know that there is MLPA, which is in a way applicable in dysmorphism also, because for microdeletion syndromes, you have MLPA kits, which will pick up the common microdeletion syndromes, which is much cheaper and very, very reliable. And obviously, you all know that syndromes like tuberous sclerosis and neurofibromatosis can also have microdeletions, and these can be picked up. And also, as Prajna also mentioned, Beckwith-Wiedemann syndrome, Prader-Willi syndrome, all these can be picked up by MLPA. Then coming on to microarray, which is very important in a dysmorphic diagnosis. And telling about microarray is actually microarray in very simple terms is simultaneous fish on the entire genome. So concurrent fish over hundreds and thousands of loci. So it's a genome-wide test, and it will tell you the imbalances, the deletions and duplications, losses and gains all over the genome. It will also tell you loss of heterozygosity, which would mean that you may be able to pick up, it may be due to consanguinity, and at times you may be able to pick up some autosomal recessive genes, because there may be this loss of heterozygosity in the particular region of the gene, and we'll have example of this later on. And you can also pick up if there is a uniparental disomy, if there is a loss of heterozygosity in a particular chromosomal location. And mosaicism up to 10 to 15% of cases. So remember, chromosomal microarray, these are old data, will pick up additionally 15 to 20% of cases as compared to karyotype when we are talking of individuals with dysmorphology. So it is advantageous because it has better resolution, it is computerized analysis, and it does not require dividing cells as compared to the karyotype. It will miss the even polyploid. It will miss the balanced abnormalities because it will only pick up if there is some loss or gain. So balanced translocation will be missed. Challenges, as in the exome sequencing, the challenges are variations of unknown significance which are there. Interpretation becomes difficult, and cost is still a problem. So these are the ACMG practice guidelines which were given as long ago as at 2010, and I don't think these have been revised. And CMA as a first-line test has been recommended in multiple abnormalities, apparently non-syndromic DD and ID, and autism spectrum disorders, and even in the prenatal, we are not talking about that, even prenatal fetal phenotypes. So then I think this is now evolving towards NGS, and we will be seeing this. But then in our scenario, we are still using karyotype. I told you that the classical phenotypes, you still do karyotype, but then many times because of easy availability and costs of karyotype, which is less, we at times still do karyotype in certain situations and get the answers. And obviously, balanced chromosomal abnormalities will only be picked up by doing a karyotype. So this is our data long back, which was published. And here we did CMA we had identified criteria for including the cases, and we had added, again, as I said, about 15% of cases, we had additional diagnosis. So we have talked about the syndromes which can be picked up under the microscope, and these are the abnormalities which are not picked up under the microscope. And there are many syndromes. I've just put up the list here, and many of the syndromes are very well known. This could be 22q deletion. This could be 1p36. This could be, as I told you, 4p. minus if the deletion is small, you may not pick it up. And as Prajna said, it can be a Prader-Willi syndrome, also Angelman caused by deletion. So these are some of the typical phenotypes of some of the microdeletion syndromes, which again with practice you can identify. So this is velocardiofacial, a 22q deletion, and this particular child had a tetralogy of Fallot, and you can see a long face, and the nose, I think, always gives us a clue. This is typical pear-shaped nose with this droopy eyelids and some puffiness of the eyes and this small mouth. So this is velocardiofacial. This is another syndrome which might not give you a very clear clue based on the dysmorphology, because they would present with developmental delay. But when these children cry, they have a unfortunately, I do not have that picture. They have a furrow on the forehead, but the neuroimaging gives you a clue because these have lesioncephaly, right? Then a very, very typical phenotype is Williams syndrome. And when you see this, you would definitely identify, once you have seen few cases, very happy social personalities. They will come in the OPD, talk to you, shake hands, hug you, very prominent eyes. And then you have this pudgy kind of cheeks and these full lips. This is called a elfin phenotype. And then this is a very typical phenotype which can be picked up. And this phenotype, which is slightly difficult to pick up, I think it is quite difficult to pick up, is a 5P minus phenotype, where the cry can give you clues, but there are subtle abnormalities which can be giving you clues. And this is one phenotype which should be picked up if you have seen few cases. This is 1P36 deletion. Apart from many other dysmorphic features, straight eyebrows, which you can see here, is one of the clues for 1P36 deletion. So this is an example of a case where based on the phenotype, the diagnosis was not made, and it was suspected to have Down syndrome, but then the chromosomes were normal. And in fact, this phenotype resembles Down syndrome. Though with experienced eyes, you can find out that this does not typically look like Down syndrome, but this is actually 9q3 deletion, which was tested MLP and CM both to confirm the diagnosis. Now, this is an interesting family, and this I have brought in just to tell you that how variable the phenotype can be. And as Prajna was mentioning about the penetrance issue, even for microdeletion syndromes, there can be penetrance issues. So this pedigree, you can see this child had, the first child in the family had congenital heart disease, who's he, and had dysmorphism and developmental delay, vertebral abnormalities, obesity, and he was doing okay with behavioral abnormalities and some developmental delay after a surgery which was done, a cardiac surgery which was done, and chromosomal microarray showed a deletion in 16p11.2 region. Then they lost two children, in fact, in the second pregnancy. In fact, the prenatal testing was done. No, I think in this prenatal test was not done, and the child also had multiple abnormalities, including a cardiac defect. Then they had a spontaneous abortion. And then in the last pregnancy, even when the prenatal was done and the child was found to have the same deletion, it was slightly advanced, and the patient's parents decided to continue with the pregnancy. So, so you can see in this pregnancy, the child had multiple abnormalities, and then the child actually died postnatally in this particular child. So now three affected individuals and the parents apparently looking normal. But when we saw the mother, she looked slightly dysmorphic. I don't have her picture, but we suspected that the mother might also be harboring the same deletion. And when the testing was done for the mother, she had the same deletion. But initially, I thought that she is a little slow in her cognitive function. But in fact, she was like average. She did not have, even on assessment, did not have IQ which was low. So an important thing here is that the phenotype can be variable in microdeletion syndromes, and the penetrance is also an issue in the microdeletion syndromes, and there are many modified genes, particularly in this particular deletion, 16p11.2 deletion, where there are huge number of articles which describe that how the phenotype can be variable because of this influence of the other genes in the genome. Prajna has talked about Angelman and Prader-Willi syndrome, a very typical phenotype of Angelman syndrome. And here the behavioral phenotype is extremely important. Happy child, walks with a broad-braced gait, can have ataxia, and then you have this wide mouth and widely spaced teeth. And this is Prader-Willi syndrome, which is again a phenotype which may be at times difficult to predict in unusual cases, but then obesity, small facial features, small hands and feet, developmental delay, and also hypogonadism, which give you clue to the diagnosis. And here, as Prajna said, CMA or methylation MLPA helps to make a diagnosis. So what I'm trying to say here is that if you do exomes here, it will not help. So if you have a phenotype which is indicating towards a particular etiology, you may pick it up in CMA if there's a deletion. But then the best test to do in these situations is a methylation specific MLPA, which will pick up almost all cases of these two syndromes. Now, coming on to the monogenic dysmorphic syndrome, Fragile X syndrome has already been talked about. So they can have a typical phenotype of large head, behavioral abnormality. Then there is a checklist also for the features, but big ears, and in later they have macroorchidism and so on and so forth. But then as a dictum, all boys with developmental with ID, developmental delay, and autistic features should be tested for Fragile X syndrome. And here it is important to know again that in exome sequencing, you will not be able to find out Fragile X syndrome. Here you have to do a specific test to pick up the CGG repeats, because this is a triplet repeat disorder, and there's a specific test which is TP-PCR. Earlier southern blotting was being done, which is very important. There are other tests also which can be done, which are based on sequencing, but specific kits are used for that. And this is extremely important to order this test if you are suspecting a triplet repeat disorder. Again, there are many syndromes which can be thought of based on dysmorphology. Noonan syndrome, Cornelia, we have already said. Then Soto syndrome, an overgrowth syndrome. And again, I find the phenotype very typical. A long face with a very prominent chin and a large head and a very broad forehead. So this is, and then an overgrowth with increased bone age. Kabuki we have already seen. This is typical mucopolysaccharidosis. Now this is, I was mentioning a metabolic syndrome, which is Zellweger syndrome, again confused with Down syndrome at times. And this is Seckel syndrome, bird-headed dwarfism, and you can see the face, which is very typical. And then this is a syndrome which is Mowat-Wilson, not very common, but I put it here because it has got two very typical phenotypic features. One is this uplifted ear lobule and this very prominent chin. These are two very important features which can, with which you can think about this particular syndrome. And these are some more examples of monogenic syndrome. This is Fraser syndrome, where you have cryptophthalmos, genital abnormalities, and syndactyly. And this is Arscock syndrome, where a typical phenotype, which we call it as shawl scrotum. Shawl scrotum is a typical phenotype for Arscock syndrome. So when you are suspecting a possible single gene etiology based on the phenotype, if you have a specific phenotype, you can do a specific test. If the gene is too big, like if you're talking of neurofibromatosis or tuberous sclerosis, and many of the syndromes, like if you have Cornelia de Lange syndrome, there are multiple genes involved. So you may have to do NGS, even if the phenotype is specific. If there is overlapping phenotypes, again, you can either use a panel or you can use NGS. And if there's a suspected single gene disorder with a non-specific phenotype with no diagnosis, then you can do NGS-based testing. And this is actually a general approach whenever you are doing testing for a monogenic disorder, and it also applies for dysmorphic syndromes. So I'm just bringing in here, as I told you in the beginning, that according to the recommendations, the first test for a child with developmental delay and dysmorphism, according to the recommendation, the first test recommended is a chromosomal microarray. And now there is evidence there in the literature, and there are many studies, and I picked up this recent study where more than 1,000 individuals, this is not specifically for dysmorphism, but this is neurodevelopmental delay, and a large number of patients will have dysmorphism, and they also have patients with congenital abnormalities. And you can see they did trioexomes where they could pick up the CNVs also, which is the copy number variations, which means deletions or duplications, which we talked about earlier, and SNVs, the single nucleotide variations, which you will pick up for monogenic disorders. So you can see the yield of trioexome was with CNV. If you are doing, the yield is 46.1%. And it will, as for SNVs, and then for CNVs it was 32%. And then you can see that even UPDs were picked up in this particular data. And this slide I've just showing you that overall what you see in neurodevelopmental disorders, in fact, the SNVs are more common. You see, monogenic diagnoses are more common in many situations as compared to the copy number variations. And they were able to pick up the copy number variations with the modified pipelines. Now they can analyze in NGS both the SNVs and the copy number variations. And you can see here that the yield was very good with for congenital anomalies also. You had more again of SNVs as compared to the CNVs in congenital malformations also. So this is actually evolving, and because most studies say that in the exome sequencing, up to 75% of the CNVs or copy number variations can also be picked up. So maybe in future, as a first test, even with the dysmorphism, we may choose to do exome sequencing with CNVs as the first diagnostic test in situations where you are not able to make a diagnosis clinically or after investigations. So this is a case, 2-year-old male diagnosed to have peripheral pulmonary stenosis, global developmental delay, and dysmorphism. And you would all agree that this is suspected rasopathy with the phenotype and the cardiac lesion. And here you can do a targeted gene panel which covers all the rasopathy gene, or you can even do a exome or a whole exome sequencing. So this is one indication where NGS-based testing is important. And now here is another case, which was quite a dilemma for us. And this was actually our mistake, which we did not do a very good clinical examination. So this was the boy whom we saw. And then this first was probably a stillbirth. This was some brain abnormality in the child. The baby was terminated. This was rubella IgM positive and the baby was terminated. And the mother came to us with 5 weeks pregnancy. So global developmental delay, dysmorphism, seizures, visual problems, brisk DTRs, all investigations normal, karyotype, MLPA, CMA, no pathogenic variants were identified. And this was the phenotype of the child. You can see puffiness, some dysmorphism, not very objective, but then hands and feet were also slightly puffy and small. What we missed in this particular child was this abnormality, this dysmorphism, which is inverted nipples here. And this is a very, very important clue for congenital disorders of glycosylation. In fact, we saw this after we got the diagnosis. So importance of making a very good clinical examination after removing the clothes of the child. And when we did an exome for this child, we found a variation in the congenital disorder of glycosylation gene. And this was confirmed by the technique, which is gold standard for making the diagnosis. But remember, IEF will not pick up all cases of CDG. So exomes are being preferred these days, and this was confirmed. So this made a diagnosis, and we were able to help the family with prenatal testing in the pregnancy. Now, this is another example where you can be totally confused even when you have all the reports with you. So this is a 3.5-year-old male child, no family history, seizures with regression of milestones and autistic features with some dysmorphism, which was not really very, very characteristic, CNS, no deficits. And again, a lot of investigations were done for this child and everything was normal. Then an exome was done for this particular child and 2 variants were identified, one in CDKL5 gene. Prajna was referring to Rett syndrome. CDKL5 is another gene which can cause Rett-like phenotype, and particularly in males, it can have a very severe phenotype. But this was a variation of unknown significance, though the phenotype was not really matching, but this could because this was a non-specific phenotype. The another variant, which was a likely pathogenic variant, was found in CUL4B, and which is also a X-linked mental retardation syndrome. So we had 2 variants, both X-linked, and now we had to sort out which one is actually the causative variant. So we tried to match the phenotype going back to the literature with our child, and you can see he seems to be matching with the phenotype with CUL4B, right? And then we did the sequencing of the mother, and mother was heterozygous for the CDKL5 and negative for the variant in the CUL4B. Now, CDKL5, it was a variation of unknown significance, and mother was asymptomatic. She could have been symptomatic, but as the phenotype was not matching very much, there is still confusion that even if it is a VUS, we really don't know. Till the time we checked, it was still a variation of unknown significance. We don't know whether it's a mixed phenotype. But then in these situations, most of the time we have to rely on the evidence which is available, and we attributed the phenotype to CUL4B. And the query was, could the mother not have clinical symptoms due to CDKL5 variant due to skewed X inactivation? But we she was normal, and this could be because of skewed inactivation. And there was a dilemma regarding prenatal diagnosis, but then how should we counsel was a problem, but we decided to counsel that the causative variant is the CUL4B. So we have to keep in mind that uncertainties may remain. Go with the best evidence based on the available evidence, but explain to the family and document the concern. Crux is a good pre-test and post-test counseling. So if you have documented in your card and explain the family that this is why you are considering this particular variant as the causative variant, and explain the family, I think you are good. Now, this is another patient, which was actually a girl and mild ID behavioral problems and dysmorphism. And when we saw this child, though she was a girl, I thought this looks like Coffin-Lorry syndrome. And this full lips, the kind of gross facial abnormalities are not seen in girls. But the phenotype of the hands was very typical, these short tapering fingers. She also had X-ray abnormalities. I don't have the X-ray as of now. And when we did the exome for this particular girl, we had identified a variant, pathogenic variant in the CUL4B gene. So, the Coffin-Lorry gene. So again, the phenotype is very variable, particularly in females, and the phenotype evolves. And in males, the phenotype, they are really very coarse and they are extremely developmentally delayed and have severe intellectual disability, whereas the females not. But then you can sort of match the phenotype of these patients with our patient, particularly the fingers and the face. Now, this was another family which we investigated for a very, very long time, and the phenotype was like Seckel syndrome, 4 children affected, all males, and we were thinking whether it is X-linked syndrome or not. But then clinically, we thought that it is Seckel syndrome, but we were not able to identify. It was long back, and we kept on doing many kinds of tests. Everything was done, FEMA was done, and we did sequencing of specific genes, but ultimately by the exome sequencing, we could identify a new variant in one of the genes causing Seckel syndrome, which is CNPJ1. So this work was done in collaboration with Dr. Thelma from Delhi University. Now, this is the final case where I would like to tell you that at times you may have to do more than one investigation in a particular family. So this family was from Nepal, and they came to us with this particular SIB who had developmental delay and dysmorphism. You can see we could not make a diagnosis, but then this was easy. This child had a Down syndrome. So we proceeded with the easy one first and did a karyotype of this particular child, and she had a translocation Down syndrome between 14 and 21 translocation, and mother was a carrier of a balanced translocation. We tested the SIB also. He was also a balanced translocation, and obviously the phenotype was not matching with Down syndrome. So the next step, which was recommended at that point in time, we did a chromosomal microarray, but chromosomal microarray did not tell us anything. But when we looked at the details, I was telling you that there can be regions of loss of heterozygosity, which may be chromosome specific. It was there in multiple regions, but then we found that there's a 11 MB loss of heterozygosity region, which was on chromosome 5. And then we searched for the genes in this particular region. We could find this particular gene, this is NSUN2 gene, where our child's phenotype was matching. And then while exome was done for this particular child, there was novel homozygous likely pathogenic variant in this particular gene, and we could explain the phenotype. So there were 2 types of disorders in the same family, and the mother, when became pregnant, we were very worried, and the family was also very worried that what will the child have? May have Down syndrome because there's a risk of Down syndrome also because of being a balanced translocation in the mother's 10% risk and a 25% chance of a recessive disorder. But then God's grace, the when prenatal was done, the fetus neither had Down syndrome nor this particular syndrome of the NSUN2 gene. So again, counseling here is important, and then because of the diagnosis, we could make a prenatal testing in the pregnancy. So finally, the approach to a dysmorphic child, as I told you, history, family history, all I have told you, single malformation, multiple malformation, presence of dysmorphism and other things. And then if you have a known diagnosis, non-specific presentation or specific clinical features or facial abnormalities, you do a specific test and you get a diagnosis. If you have a specific clinical features and you can do targeted tests, we talked about microdeletion, we talked about monogenic disorders, and you make a diagnosis. And then if you do not have a diagnosis, CMA was recommended, and still it is a recommendation to do CMA first. And then you have if you do not have a cause identified after CMA, then you go on to do next generation sequencing, and then you do counseling. But as I told you, literature is evolving now that at this step only we may go on to whole exome sequencing with copy number variation testing. There is growing evidence, but mind you, this is not a recommendation now. And many times we are in a dilemma whether we should do CMA in this child and we should do exome with CNV. And that decision is being taken on individual basis based on the clinician's decision, and we may be wrong or right in taking a decision. So finally, as I told you, in a significant proportion of cases, you may not have any diagnosis, and we are so frustrated that at the end of the day, when we have done everything, there is no diagnosis. But I think there is nothing more stimulating than a case where everything goes against you. And mind you, it is better than a wrong diagnosis. If you do not have a diagnosis, explain the family, write on the card that we do not have any diagnosis. Follow-up is extremely important. Search literature, keep going back to the case. Maybe some more cases have been reported. And then family should understand everything what you know. I think it is more important for the family to know what you don't know. And I don't think we should feel embarrassed about it, that we are not able to sort out the case and we do not know what is happening, because we should not give wrong information. And then overall, it may be a new syndrome, and you may be the first person to diagnose a new syndrome. So to conclude, we are in exciting times in medical genetics. Newer technologies are rapidly getting from bench to bedside. AI-based diagnosis. You may go back from genome to phenotype, but then and then you have, as I told you, have to be very judicious in ordering a test and interpreting. But to my mind, and I think for all clinicians like this, no test can replace a good history and clinical examination. Even if you have a variant identified in exome or a CMA, you have to go back to the phenotype and then match. If the phenotype doesn't match at all, you cannot label a child with that particular syndrome. And we have to also keep in mind the cost in the resource poor setting. So I would end here with acknowledging my colleagues, my residents, many other departments and funding agencies who have helped us in making diagnosis of children with developmental delay and dysmorphism, and many other, and the collaborators who have helped me out. So thank you very much for your patient hearing, and I would be happy to answer any questions. Thank you very much.
Thank you, ma'am. It's a nice presentation and having more case scenarios. And one question from senior most Tilak Chandra Pal sir is a professor in pediatrics in Nilofer, and now he is working at the Nice Children's Hospital. He had question: why do Downs loses resemblance to parents but resembles each other? That is the question from Dr. Tilak Chandra Pal sir, madam.
So the phenotype is because of the trisomy of 21. Okay, and that's why this phenotype is quite typical. But if you see large number of patients with Down syndrome, even they have phenotypic variability. So there is influence of the parents' phenotype also. It is not there, but because this imbalance is so huge, one extra chromosome is there, and this phenotype is so typical, they would resemble each other. But then if you see a large number, there may be some difference. some patients may have a milder phenotype, and it is not always associated that if you have a mosaicism, you have a milder phenotype. So the phenotype is variable. They may have some resemblance to the parents, but the typical phenotype is because of this large chromosomal large chromosomal copy gain. The gain of one extra chromosome causes this particular phenotype.
Okay. Okay. There's only one question. And I acknowledge the presence of Surendranath Garu and senior most doctors in the Telangana state. And really, you made us today's Sri Ram Navami more colorful, madam, with your talk and other things. And now I request Sunkoj Bhaskar sir to say comment on the things, and we'll go ahead, sir. Sir, Sunkoj
Before
Bhaskar.
thank you, Dr. Sridhar. And before I talk, Dr. Prajna, you may be having some closing remarks. Over to Dr. Prajna.
Yes, sir. Thank you, sir. So I would like to thank Madhulika madam for that excellent talk. I think madam has beautifully highlighted all the important aspects of what we need to consider in the clinical approach to a child with dysmorphic features, and also how to proceed further with the evaluation, including the ancillary lab investigations, the imaging studies, and the relevant genetic testing for confirming the diagnosis. We are very grateful, ma'am, for sparing your Sunday morning and sharing all your experience and expertise with us, and all the images of all the patients that you have shown us were also very, very enlightening, because in dysmorphology, we know that, as you have also pointed out, some of these conditions have a gestalt diagnosis. So even if we see the typical images once, we are able to remember those and recall those when we see these children in the clinic. And with these images in mind, we are able to come to some sort of a differential diagnosis. Of course, there's always a bit of caution involved here. We should not always jump to a gestalt diagnosis, because ma'am has already also highlighted the fact that there could be overlapping phenotypes. And although we can keep these differential diagnoses in mind, we should not label a child with a particular diagnosis unless and until we have confirmed it with the relevant genetic testing and we are absolutely sure that that is a condition that the child has. And based on that only, further prognosis, management, and counseling should be done after confirming the diagnosis, and not just with a label based on a clinical suspicion alone. So thank you very much, ma'am, for highlighting all these important aspects. And we are really very honored and privileged to have you here with us today. Thank you, ma'am.
Yeah, thank you, Dr. Prajna and Madam Dr. Madhulika. It was like a cinema for 60 minutes, a cinema with colorful pictures, colorful faces, and good presentation. Presentation was like a music to the ears. We didn't know how come we sat without moving away from the screen for more than 84 minutes. That is the wisdom of a senior person like you, and we are really indebted to you. Indebted to you. We thank you very much. I thank Dr. Prajna and Dr. Madhulika Madam. I acknowledge the presence of Dr. Chandrasekhar, who happens to be your student at AIMS New Delhi. He's also there.
Madam, hope you remember me.
Yes,
This is
I do.
Chandrasekhar 92 batch.
Thank you.
Convey my regards to Sushil sir also. Happy to see you and really enjoyed your talk.
Thank you.
So the inverted nipple, it goes in favor of CGD.
CGD. Yeah, but then all CGD patients will not have inverted nipples. So CGD
Okay.
is actually a very large. I mean, many phenotypes. There are many types of CGD, and you may not find typical facial features. Also, there may be only MRI abnormalities. But then I was just talking about dysmorphology, so I brought this out here.
Thank you. Thank you so much, madam.
Thank you.
Nice to see you after a pretty long time.
Yeah, same here.
Thank you, madam. I wish you a very happy Sri Ram
Thank
Navami.
you very much, sir. Thank you very much for giving me the
It's a real,
opportunity.
it's a real day of festival with medical knowledge and spirituality. Thank you, and Dr. Sridhar, please
Yeah.
take over.
Thank you, one and all, for attending today's fourth genetics webinar. And special thanks to Madhulika madam, and thanks to regards to Prajna madam, who is the coordinator for this all the genetics webinars, and also today's guest, Dr. Murki Srinivas sir. I thank everyone and all the doctors, senior doctors, and all the faculty and all the delegates who had joined today's webinar. Thank you. See you next month, first week, first Sunday, morning 9 a.m. with fifth webinar, genetics webinar. Thank you. Thank you, one and all.
Thank you.
Thank you, sir.